Labor. In this presentation, we hope the viewer learns to appreciate the stages of labor, to understand the steps in the management of labor, and to be able to identify possible problems that may arise. Labor and its stages. Labor is defined as the process whereby the fetus and the placenta are delivered from the uterine cavity after the 24th week of gestation. It is diagnosed in the presence of regular, painful uterine contractions, cervical dilatation, and cervical effacement. It is also commonly accompanied by the presence of vaginal show and rupture of fetal membranes. There are 3 stages of labor. The first stage begins upon diagnosis of labor and ends at full cervical dilatation. It is divided into 2 phases, the latent phase and the active phase. The latent phase of labor is associated with cervical dilatation of 0 to 3 centimeters, associated with irregular contractions. The active phase of labor is associated with cervical dilatation of 3 to 10 centimeters, associated with regular contractions. The second stage is defined as the period of full cervical dilatation till the delivery of the fetus. The third stage is defined as the period from delivery of the child till the expulsion of the placenta. The mechanism of labor is commonly attributed to the 3 P's. These are power, passage, and passenger. Power refers to the uterine contractions which generate force for expulsion of the fetus. Passage refers to the birth canal, which is comprised of the bony and muscular pelvic walls along which the fetus travels during labor. Passenger refers to the fetus. There are several processes the fetus undergoes from the onset of labor till delivery. Firstly, stage 1 of labor involves the engagement and descent of the fetus. Engagement refers to the passage of the widest diameter of the presenting part beyond the pelvic inlet. Descent refers to the downward passage of the presenting part through the pelvis. Next comes several steps in the second stage of labor. Head flexion. This occurs as the head of the fetus meets the bony resistance of the pelvic floor. This process aids in producing a smaller diameter of presentation for facilitation of the delivery. The occipito-posterior diameter is then converted to the smaller and more optimal suboccipitobregmatic diameter. Internal rotation. This occurs as the head of the fetus meets the muscular sling of the pelvic floor. The occiput rotates anteriorly from the lateral position towards the pubic symphysis. Extension. This happens as the head descends to distend the pelvic floor and the vulva is followed by a phenomenon known as crowning. Crowning is when there is maximal distension of the perineum and introitus that accompanies the final expulsion of the fetal head. Restitution. The fetal head rotates back to be in line with the shoulders. Lastly, delivery of the fetal shoulders. The anterior shoulder is delivered first via posterior traction of the fetal head. The posterior shoulder is then delivered by lifting the fetal head anteriorly over the perineum. Stage 3. Placental separation occurs next, and this is known as the third stage of labor. This usually occurs 30 minutes after delivery of the fetus and lasts between 5 to 10 minutes. Signs which precede placenta separation include a show of bright red blood, apparent lengthening of the umbilical cord, and elevation of the uterine fundus. In the assessment of labor, it is important to take a thorough history of the patient's symptoms of labor as well as perform a complete physical examination. The history taking should include a confirmed gestation, any significant antenatal problems, and the presenting symptoms of labor. Physical examination should be focused at assessment of the degree of cervical dilatation and effacement, as well as frequency of uterine contractions. Other important findings include the fetal lie-in presentation, the presence of fetal membranes, the color of the liquor, and the descent station of the fetal part. CTG is also an important tool in the assessment of the frequency of uterine contractions, as well as the monitoring of fetal well-being. Fetal lie describes the relationship of the long axis of the fetus to the long axis of the mother. Normal lie is when the fetus is longitudinal and the axis of the fetus is in line with the long axis of the mother. Examples of abnormal lie include transverse or oblique. Fetal presentation may be described as cephalic when the baby's head is the presenting part, or breech when the baby's head is pointing upwards. The most optimal presentation is when the baby's head is cephalic and flexed, and the presenting diameter is the smallest. The suboccipitobregmatic diameter is at 11.5 cm. Malpresentation is when the head is extended or laterally flexed, resulting in wider presenting diameters. Extended attitude is when the fetal head is extended and results in a larger presenting diameter. Ansynclitism is when the fetal head is laterally flexed. Active management of labor. This involves continuous assessment of the stages and progress of labor and conscientious monitoring of fetal and maternal well-being. Cervical dilatation is the opening up of the cervix during labor and is measured in centimeters, ranging from closed to fully dilated at 10 centimeters. Cervical effacement is the thinning of the cervix during active labor and is measured in percentages, 100% indicating a fully effaced cervix. Fetal engagement refers to the process where the presenting part of the fetus meets the pelvic floor. This may be assessed via abdominal palpation. Fetal station depicts the relationship between the fetal presenting party and the maternal ischial spines. Station 0 is when the fetal head is at the level of the ischial spines. Station 1, 2, and 3 is when the presenting part is beyond the ischial spines. Stations -1, -2, and -3 is when the presenting part is above the ischial spines. The partogram. This is a graphic representation of the progress of labor and includes the serial charting of the cervical dilatation and effacement, frequency of uterine contractions, any induction or augmentation agents utilized, the fetal heart rate, and the maternal vital parameters. Attention is drawn visually to any deviation from the normal progress of labor. It commences from the diagnosis of active labor and ends upon delivery of the fetus, or at the end of 12 hours of active labor. The alert and action lines on the partogram are based on the principle that the cervix dilates at 1 centimeter an hour during active labor. The alert line is drawn at the start of active labor and is a vertical line of progression of 1 centimeter an hour. When the progress of labor moves beyond the alert line, this may indicate obstructed or unsatisfactory progress of labor, and extra vigilance should be exercised. The action line is drawn parallel to the alert line, 4 hours apart, representing an acceptable range of 4 hours of lag time. When the progress of labor moves towards or reaches the action line, active measures towards delivery should be taken. Prolonged second stage of labor is defined as lack of continuing progress for 3 hours with regional anesthesia or 2 hours without regional anesthesia in a nulliparous lady, or lack of continuing progress of 2 hours with regional anesthesia or 1 hour without regional anesthesia in a multiparous lady. This can be differentiated into prolonged active phase of labor or secondary arrest of labor. Prolonged active phase of labor is defined as a slow rate of cervical dilatation less than 1.2 centimeters per hour in the nulliparous and less than 1.5 centimeters per hour in the multiparous woman. This is usually attributed to insufficient or incoordinate contractions, cephalopelvic disproportion, fetal malpresentation or malposition, or excessive sedation. On the other hand, secondary arrest of labor is defined as complete cessation of cervical dilatation and descent, when there is no change in cervical dilatation over a period of 2 hours. This is usually attributed to cephalopelvic disproportion or obstruction, fetal head malposition, and excessive sedation. Successful management of labor compromises both active and supportive measures. Active management of labor involves the prompt diagnosis of labor, induction of labor via early amniotomy and oxytocic agents, and augmentation of labor via oxytocic agents to ensure optimal frequency and intensity of uterine contractions. In the third stage of labor, administration of oxytocic agents and clamping of the cord with application of traction helps reduce complications such as postpartum hemorrhage. Supportive management of labor involves adequate analgesia, maternal hydration, and emotional support throughout labor.